A very good evening and a very warm welcome. I, myself, Vaishnavi Marathe, would like to welcome you all on behalf of Pharm D Community for today's session on inflammatory bowel disease, Crohn's disease, by Dr. Deepak Madhu sir. I'm thankful to all the participants on Zoom and YouTube who have spared their valuable time for this today's session of gastroenterology series. Pharm D Community is created with a charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitating and fostering education and awareness in our chosen field of pharmacotherapeutics. Organizing this event wouldn't have been possible with the wholehearted support of all the core committee members and the newly joined Pharm D community members. I'd once again like to thank all the government officials and our speakers who have contributed towards this socio-educational cause. Our upcoming webinars is on Saturday, that is 27th of February uh, at 7 p.m. by Dr. Neeraj Vinaya Kumar sir on inflammatory bowel disease, ulcerative colitis. And another one is on Sunday, that is on 20th of February at 11 a.m. colorectal cancer by Dr. Neeraj Agarwal sir. I request you all to stay tuned on YouTube for further updates regarding the session. I am thankful to our speaker for today, Dr. Deepak Madhu sir, who is one of India's eminent gastroenterologists, uh, and for this today evening talk. I'd like to hand over the session to my teammate Anmol for the kind introduction. Over to you, Anmol.
Thank you, Vaishnavi ma'am. Once again, on behalf of Pharm D Community, I welcome you all to today's session on BID Crohn's disease. Today, we are privileged to have one of the renowned gastroenterologists, Dr. Deepak Madhu sir. Dr. Deepak Madhu sir is trained in gastroenterology at All India Institute of Medical Science, New Delhi. Sir has special interest in inflammatory bowel disease and therapeutic endoscopy. And Sir is currently working at Caritas Hospital, Kottayam. Dr. Deepak Madhu sir is actively involved in research and has published multiple articles in international journals. Sir was a recipient of Outstanding Poster Presenter Award at American College of Gastroenterologists Annual Conference 2020, which was held in Chicago. Sir is a peer reviewer of several international journals. With this brief introduction, now I hand over this section to an honorable guest of today's session, Dr. Deepak Madhu sir. Over to you, sir.
Thanks a lot, Anmol, for the kind words of introduction. Thanks a lot to Aishwarya Nair and Vaishnavi and everyone in the Pharm D community for giving me this opportunity to talk about Crohn's disease. So I'll briefly be Crohn's disease is a very huge topic. I'll only be skimming through the topic in this session. So I think we'll go directly to the presentation itself. Can you see my screen?
Yes, sir, it's visible.
Okay, so Crohn's disease is a chronic inflammatory condition affecting the intestine. It can have transmural involvement of the intestine, can have granuloma formation in histology, can affect the gastrointestinal tract anywhere from the mouth to the rectum, and can have luminal as well as extraluminal manifestations. So, what is the pathogenesis of Crohn's disease? So, as I told you, inflammation is characteristic of Crohn's disease, transmural inflammation. How does inflammation start, or what triggers inflammation in the bowel? There are a lot of things that play a synergistic role, but dysbiosis is one of the most important factors involved in this. You can see here on on the left side of the screen. This shows the healthy gut with healthy microbiota, high bacterial diversity, high phage diversity, photovirales, and high fungal diversity. And the gut is pretty much healthy here. But when in a dysbiotic environment where the bacterial diversity decreases, the photovirales richness increases, and fungal diversity decreases, it's a milieu for IBD to be triggered in people with predisposition. So when the gut microbiome, that is bacteria, phages, and fungi are dysbiotic, it leads to a series of processes which lead to gut barrier disruption. So the gut barrier gets disrupted, leading on to entry of pathogen associated molecular patterns and PAMs and DAMs into the uh, uh, lamina propria, triggering a series of inflammatory responses, which lead to which leads to an inflammatory cascade, which ultimately leads to apoptosis and apoptosis of cells and increased inflammatory infiltrate to the intestine. So, how common is inflammatory bowel disease in India? How common is Crohn's disease in India? So, a couple of decades back, Crohn's disease was thought to be non-existent in India, just like celiac disease. But over time, uh, it is being increasingly recognized in the Indian population. There have been two epidemiologic studies conducted in India, one in Hyderabad in 2011-2013 period, in which the incidence of Crohn's disease was found to be 3.91 per 100,000. It's not as common as celiac disease. Celiac disease, we discussed in the previous class that the prevalence of celiac disease is 1%, whereas 1 in 100, whereas Crohn's disease is much less frequent. In another study which was conducted in Punjab by Dr. Su found that it is around 6 per 100,000. So what are the clinical features? What clinical features would prompt you to uh, think that Crohn's disease is present in a patient? Most common symptoms are luminal symptoms, that are symptoms which indicate bowel involvement, includes diarrhea, bleeding, anemia, features of malabsorption, weight loss, intestinal colic, that is severe abdominal pain arising from the intestines, and even intestinal obstruction in some cases. While diarrhea and bleeding, and anemia, and malabsorption, all these four symptoms indicate mucosal involvement alone. Intestinal colic and intestinal obstruction indicate transmural involvement. That is involvement of the muscles, involvement as deep as the muscle layer. So, since systemic inflammation is an integral component of Crohn's disease, several extra intestinal manifestations also are known to occur, which include, something as common as aphthous ulcers, to something much more severe and uncommon, like pyoderma gangrenosum, scleritis and episcleritis, and skeletal complications like sacroiliitis. So, how is Crohn's disease diagnosed? It requires a combination of imaging, endoscopy, and histopathology. Imaging is usually, it's usually the small bowel which is predominantly, or small bowel or not large bowel, which is usually involved predominantly in Crohn's disease. And for evaluation of this, one of the first investigations is usually a CT angiogram, and it's selected cases. It could be an MR angiogram, depending on the availability and expertise in a center. It could be either of these. Most commonly, it's a CT angiogram. It could be an MR angiogram as well. So, what is seen in a CT angiogram? A CT angiogram, typically, bowel thickening is seen with mucosal enhancement. As you can see, there is enhancement of the bowel mucosa, and the bowel wall is thickened as well. So you can see it here as well. Bowel wall is thickened. Bowel itself is dilated. There is narrowing and mucosal hyper enhancement. These are features which are typically seen in Crohn's disease. Then comes endoscopy. In some situations, it could be an endoscopy. An endoscopy could predate a CT or a cross-sectional CT or MR. So endoscopy, it's typically colonoscopy that you lower gastrointestinal endoscopy. In cases with colonic or ileal involvement, a colonoscopy would usually suffice to gather endoscopic information as well as for taking biopsies. So most commonly, their mucosal edema is a very common, finding in these patients. There could be ulcers which are linear. Ulcers which you can see are, if an ulcer is like this, you call it a transverse ulcer. This is a linear ulcer. It's along the axis of the So linear ulcers. These are also linear ulcers. These are predominantly along the axis, and you can call them serpiginous as well, because it's it has a serpentine course. So these serpiginous ulcers are also characteristic of Crohn's. There could be in severely inflamed colon. It could be friable and spontaneous using blood, as you can see in this case. And in long-standing Crohn's, there could be multiple pseudopolyps that have formed. These are the endoscopic appearances of Crohn's disease, of a patient with Crohn's disease on colonoscopy. In patients with isolated small bowel involvement, that is not involving the terminal ileum, it could be a small bowel enteroscopy, which would give you the information required. The endoscopic visualization that is required would be obtainable only by a small bowel enteroscopy and not by a colonoscopy in deep small bowel involvement, which is not involved in the terminal. So once you've done an endoscopy, you take biopsies, and the most common findings are inflammation, acute and chronic inflammation, cryptitis, cryptapsis formation. The crypts would be inflamed, and with neutrophilic infiltration, we call it cryptitis or cryptapsis. And in some cases, granulomas could be seen. And granulomas are, very pathognomonic of Crohn's disease. There is another disease which very commonly produces granulomas in the intestine, and that is tuberculosis. It is very relevant in our community in India, but not so relevant in the West. So differential diagnosis include intestinal tuberculosis, very common differential diagnosis of Crohn's disease in India. Behçet's disease is another common differential diagnosis of Crohn's disease. Intestinal ischemia and even ulcerative colitis can be differentials of Crohn's disease. So it's very often, Crohn's disease is very often confused with intestinal tuberculosis, especially in India, because most patients with ulcers and strictures of the intestine are likely to be more likely to be to be having intestinal tuberculosis than Crohn's disease in India because of the high prevalence of intestinal tuberculosis. Bassett's disease, mesenteric ischemia, and ulcerative colitis all are differentials of Crohn's disease, but the diagnostic confusion is limited to limited to only a few cases in most circumstances. Bassett's disease, intestinal ischemia, and ulcerative colitis, none of these diseases produce granulomas. Intestinal tuberculosis, on the other hand, produces almost all the. It's a great member of Crohn's disease. It produces almost all the uh, changes that Crohn's disease produces in the intestine, including histopathologic changes. How do you differentiate? High prevalence areas with tuberculosis, distinguishing the two diseases may be difficult, and multi-parameter models may have to be employed. Multi-parameter models are models which include a combination of clinical, radiologic, endoscopic, and radiologic criteria. But even with all these tests, and sometimes tests like Manto and biochemistry and specialized tests which include uh, interferon gamma release assays, etc., may also be resorted to in select cases. But in the end, in a lot of cases, it's very difficult to differentiate the two diseases. So how do you circumvent this problem in India? Empirical antituberculous therapy would have to be resorted to. So if it's a case of tuberculosis and you start treatment for Crohn's disease, which includes immunosuppressants, tuberculosis is likely to be flared up, and the patient is going to uh, be much more sicker than he should be if treatment for Crohn's disease is started instead of that for intestinal tuberculosis. So you may have to resort to antituberculous therapy. Patients with mild or moderate Crohn's disease, it's an empirical ATT is given first to differentiate in cases with diagnostic confusion. And response assessment is done with a combination of clinical, endoscopy, radiologic, and biomarkers. In cases of non-response to ATT, the disease is presumed to be Crohn's disease, and crossover should be made to the treatment of Crohn's disease. So, what is the usual duration for which antituberculous therapy should be continued? It's usually 3 months, but it's not sacrosanct. It's not a watertight, but it can be changed on a case-to-case basis. So, but as a general rule, if a patient does not respond to antituberculous therapy for 3 months, even for 3 months, the patient is unlikely to have intestinal tuberculosis, and he should be perceived to have Crohn's disease and start working with Crohn's disease. Once a diagnosis of Crohn's disease is established, you need to classify the disease by the Montreal classification. Uh, based on age, location, and behavior. So, younger patients would be A1, middle-aged A2, and a little older people would be A3. People with ileal disease alone would be classified as L1 disease, colonic disease as L2, ileocolonic disease as L3, and upper GI disease as L4. Purely mucosal involvement would be B1, structuring disease would be B2, fistulizing disease would be B3, and perineal fistulizing disease would be B3 with the suffix B. So once a patient has Crohn's disease, you classify the disease phenotype into by Montreal. It could be, if it's a 30-year-old person with Crohn's disease, that is limited to the ileum. Structuring Crohn's disease that is limited to the ileum, it would be A2, B1, B2. Structuring disease limited to the ileum would be A2, B2, L1. For example, just for illustrative purposes. And if it's a patient with, it's a 50-year-old patient with colonic Crohn's that is limited to mucosal involvement, it would be A2, B1, L2 for illustrative purposes. Then you move on to severity assessment. It's usually done by the Crohn's disease activity index. Usually done by the Crohn's disease activity index, which includes, or CDI for short. It includes, the severity of diarrhea, the severity of abdominal pain, the extent of general well-being, extraintestinal manifestations, requirement for antidiarrheal drugs, the presence or absence of an abdominal mass, the severity of anemia, and the severity of weight loss. All of these together would constitute the Crohn's disease activity index, or C. The Crohn's disease activity index, or CDI. So, what would be the treatment options? What would the treatment options be? The treatment options for Crohn's disease includes, we have a plethora of drugs, an armamentarium of drugs at our disposal to fight Crohn's disease. The simplest of these drugs would be, anti-inflammatory drugs such as mesylazine, and antibiotics such as fluoroquinolones, metronidazole, and even rifaximin. Immunosuppressants that include steroids, methotrexate, azathioprine, 6-mercaptopurine, etc. Biologics that include anti-TNF agents such as infliximab, adalimumab, certolizumab, and other biologics such as vedolizumab and ustekinumab. So, treatment strategies for Crohn's disease include 2 steps. First step in the management of Crohn's disease is induction of remission. The second step would be maintenance of remission. So what exactly, if a patient has active disease with symptoms, first step is to make the patient symptom free. That is induction of remission. The patient may require steroids, biologics, or even exclusive enteral nutrition. And in some cases, surgery can also be a part of induction of remission. And once the patient has achieved response by any one or combination of these agents, the next step is to prevent the next episode of Crohn's disease, the next episode of symptoms. And for that, you may have azathioprine, methotrexate, and biologics, which are the most common agents used for maintaining remission in Crohn's disease. So there are a large number of biologics that are, a lot of biologics that are being developed everywhere. But a few of them only are available in India. Among the anti-TNF category drugs, which are the most important drug biologics for the management of Crohn's disease, infliximab is available in India. And infliximab biosimilars are also available in India. I think most of you would already be knowing the difference between a biologic and a biosimilar. As far as adalimumab is concerned, only the biosimilar is available in India, and the biologic, that is Humira, is not yet available in India. And anti-integrin inhibitor vedolizumab is available in India in the originator biologic form. Whereas other biologics such as anti-TNF biologics such as certolizumab and golimumab are not available in India, and anti-interleukin biologics such as ustekinumab is also not available in India. Apart from drugs, surgery is another modality by which you may have to tackle Crohn's disease. It can help induction of remission in by resection of localized disease. It may have to be resorted to in cases of refractory disease, sometimes in fistulizing disease, very commonly in perianal disease, very commonly when the patient has obstruction that is not responding to conservative management. When patients have fibrotic complications, this is probably the only solution we have. And sometimes when we have bleeding that is refractory to other modalities. This is not an exhaustive list of all the reasons why a patient with Crohn's disease would require surgery, but these are the very common indications for which surgery will have to be resorted to when you're caring for a patient with Crohn's disease. But there are lots of other indications for surgery as well. So, how do you say a patient with Crohn's disease has active disease? It's defined as a Crohn's disease activity index score of more than 220. Active disease is when the patient has a activity index of more than 220. Remission is when the activity index is less than 150, and you can say that a patient has responded to a certain modality of treatment when he or she has had a decrease in Crohn's disease activity index by a factor of 100 points. Relapse is when a patient gets active disease after having achieved remission once. Once a patient has achieved remission, you're trying your best to maintain that remission. But if the patient gets another episode of active disease, then you call it a relapse. And all relapses are not the same. Early relapse is when the patient gets active disease within 3 months of achieving remission. Infrequent relapse is when the patient gets one or less episodes of relapse in a year. Frequent relapse is when the patient has 2 or more episodes of relapse in a year. Refractory disease, you call Crohn's disease very commonly responds to steroids, but you can call it steroid refractory if a patient with Crohn's disease does not respond to prednisolone at a dose of 1 milligram per kilogram given for a period of 4 weeks. The patient does not respond to this dose and duration of prednisolone. It's called steroid refractory. Steroid dependent is when the requirement of prednisolone is more than 10 milligrams per day, or when the budesonide requirement is more than 3 milligrams per day over 3 months. Relapse is when relapse within 3 months of stopping steroids is also counted as steroid dependent disease. Localized disease is when the extent of disease is less than 30 centimeters in extent, and extensive disease is when the cumulative extent of disease is more than 100 centimeters of involvement in the gut. So, like I said, agents for induction of remission include steroids, which include the budesonide and prednisolone. Biologics, which which could include infliximab, adalimumab, ustekinumab, and vedolizumab. And even surgery can be used in selected cases to induce remission, following surgically induced remission. So, how do you choose the treatment modality? For mild disease that is localized to the small intestine or the ileocecal area, you can make do with budesonide alone. Budesonide alone is sufficient. The risk of systemic toxicity of steroids is less with this agent, so it's preferred in such cases. Cases with moderate localized small intestinal, moderately active, localized small intestinal or ileocecal involvement, you can make do with budesonide or prednisone. It depends on the person, and it depends on on case-to-case basis. You could choose either of these medicines. In severe disease that is localized small intestine or IC region, prednisolone biologics such as anti-TNF, most commonly anti-TNF drugs, should be used. Chronic disease is usually prednisolone and almost never budesonide, which takes takes the role of first line agent. It's almost always prednisolone. In extensive disease, prednisolone and anti-TNF are the preferred modalities for inducing remission. So, which agent should be used? Like I said, it could be prednisolone, it could be biologics as well. It could be prednisolone, it could be biologics as well. Which agent to use? There are two strategies. One is the step-up strategy, where you start with, less toxic, less active agents, and then work your way up to biologics if the patient does not respond. It is a step-up approach. Usually, a patient with moderately or severely active disease, you start with corticosteroids plus or minus immunomodulators for inducing remission. And if the patient fails to respond adequately, you step up to biologics. That's a step-up approach. Another school of thought is to use biologics, hit hard and use biologics in the first instance of active, moderate or severely active Crohn's disease. Start using biologics, and once the patient has responded well and has been on remission for quite some time, taper down and maintain him further on immunomodulators. That's a top-down strategy. There is a difference in practice between centers on which of these approaches are to be used. Some centers use the step-up approach. Most centers use the step-up approach, whereas some centers around the world use the top-down approach. Once the patient has achieved remission, the next step is to maintain the remission, to avoid another relapse. For these, patients who have experienced who have achieved remission on steroids, azathioprine, steroid-sparing agents such as azathioprine or 6-mercaptopurine or methotrexate can be used to maintain remission. Whereas patients who have achieved remission on anti-TNFs may have to be continued on anti-TNFs for some more time and then tapered down treatment modulators alone. And very often, and it's customary, it's almost needed to prescribe azathioprine or immunomodulator along with anti-TNF for a period of time, so that antibodies to anti-TNFs don't develop these cases. So anti-TNFs in combination with azathioprine, 6-month epidural or methotrexate has been shown to be superior to anti-TNFs alone in maintaining remission. So what if the patient required surgery, like localized multicenal disease? We had discussed that surgery would be required for induction of remission. Or if the patient fails multiple agents, surgery may have to be used as a rescue or salvage agent. In patients who have a surgically induced remission, there is a risk of recurrence. So you may have, depending on the risk of recurrence, the patient can be prescribed antibiotics, 5 ASAs, immunomodulators such as azathioprine and 6-month epidural, and even biologics may be required in very high risk patients and patients who have failed other agents to maintain remission. Other agents that are used in the management of Crohn's disease, we were discussing mostly about anti-TNFs. Steroids and anti-TNFs are the mainstay of treatment. It depends on it depends on the center which agent to use first. But both these drugs are, first-line agents or legitimate agents that are very commonly used to induce remission. But what if the patient has failed one or more of these agents and is not yet a surgical candidate? There are other drugs that come into play. One is vedolizumab, which is an alpha-4 beta-7 integrin inhibitor. It's a gut-selective integrin inhibitor. It's a very safe drug as compared to anti-TNFs. It's much more safer, but it's less active in Crohn's disease. But it does have a place in the management of Crohn's disease, especially in the management of chronic Crohn's disease. Then you have ustekinumab, which is not yet available in India, but it's a fairly good active agent which is coming up in the management of Crohn's disease. It's getting its place in the management of Crohn's disease. Till you can 12-23 antagonists. And there are again a few investigational agents. This is by no means an exhaustive list of investigational agents, but just for discussion, these are a couple of investigational agents that are being evaluated in the management of Crohn's disease. One is semaglutide, zachisumab, anti-IL-23, tocilizumab. We are already very familiar with tocilizumab, given its utility in the management of Crohn's disease. COVID, severe COVID disease. Tofacitinib, which is a JAK3, JAK1 inhibitor, which is a selective JAK1 inhibitor. There are drugs such as mongersen, which these are not available in India. None of these are except tocilizumab and tofacitinib. Both these drugs are available in India. These two drugs, but neither of these drugs have been, shown to be, very good agents for Crohn's disease. Then filgotinib is undergoing trials in India. Mongersen is also another drug which is being evaluated for the management of Crohn's disease in selected patients. There are a lot of other agents also which are being investigated. This is just a tip of the iceberg, I would say. By that, I come to the end of the discussion. Thanks a lot. You can email your queries or WhatsApp me the queries, or you can directly, if you're watching this at a later date, or you can directly ask me right now if you're watching this live. Thanks a lot.
Thank you, sir, for such an informative and interesting session. So, sir, as you were streaming, there are a few questions. So, can we take them up?
Yeah, sure.
Okay, the first question is, what are the newer biochemical markers available for Crohn's disease?
One second. Let me stop sharing. So, the newer biochemical biomarkers which are used. There are, I haven't discussed biomarkers at all in the discussion. There are newer as well as old well-established biomarkers which are used in the management and follow-up of Crohn's disease. Very commonly used biomarker would be C-reactive protein, uh, which is CRP or CRPS. It is very commonly referred to. CRP is a very useful agent in the biomarker in determining if Crohn's disease is active or not. Another biomarker which is very important is calprotectin, fecal calprotectin, which is the levels of which would help in defining remission, in ruling out Crohn's disease in some cases when you're confused if the patient has Crohn's disease or inflammatory or irritable bowel syndrome. Calprotectin may help in ruling out Crohn's disease or ulcerative colitis. It can help in the quantitative levels of fecal calprotectin would help in determining how severe the disease is, to predict the clinical course of the disease, whether it is steroid refractory or steroid dependent, and also in predicting relapse of the disease, in defining remission. In all of these instances, fecal calprotectin and in some instances fecal lactoferrin has also been shown to be relevant and important. And very old markers such as ESR, but it has gone down in importance. CRP has almost replaced all of the indications of ESR, at least in the management of Crohn's disease.
Thank you, sir. Another question is it possible to have a false positive IgRA in case of active Crohn's disease?
Yes, it's quite possible for IgRA to be positive, but in a patient with active Crohn's disease, it could the patient could be having positive IgRA. Doesn't mean the patient does not have Crohn's disease. The patient would very well be having Crohn's disease. He or she could be having a latent tuberculosis as well, in addition, or the disease could be intestinal tuberculosis to start with itself. It requires evaluation, proper clinical evaluation to determine which of these is happening here. But why is a positive IgRA relevant in a case of Crohn's disease? If a patient definitely has Crohn's disease and he or she has IgRA positivity, how is it relevant? It's relevant when you start when you're starting infliximab or adalimumab, one of the anti-TNF agents. When you're planning to start one of the anti-TNF agents, a positive IgRA creates some amount of problem, because anti-TNFs are very commonly implicated in in a flare of tuberculosis. It can flare up a latent tuberculosis. The patient has Crohn's disease and IgRA positivity, and he or she is being planned for anti-TNF agents. You will have to be very careful, and in some cases even co-prescription of anti-tuberculosis drugs may also be necessary to prevent flare. Anything else?
Yes, sir. Can the use of stem cell therapy in the treatment of Crohn's disease can be considered as an effective method?
So yes, stem cell therapy is mesenchymal stem cell therapy derived from adipocytes has been shown to be effective in the management of refractory perianal Crohn's disease, not in intestinal Crohn's disease, but in perianal visualizing type perianal Crohn's disease, which has failed multiple modalities like anti-TNF agents and immunomodulators. To avoid surgery, stem cell therapy can be considered as an option. there have been multiple trials around the world, and there are trials going on in India as well, the All India Institute of Medical Sciences as well, which are evaluating the utility of mesenchymal stem cell therapy for the management of refractory perianal Crohn's disease. But it does not have any role in the management of intestinal extensive or localized intestinal Crohn's disease. But perianal Crohn's disease definitely has a role. It may not be very effective. Maybe the response rate would be something around 50 to 60% of refractory cases may respond to stem cell therapy. Anything else?
Yeah, thank you, sir. One more question is there. How can we differentiate Crohn's from cell sept or mycophenolate GI toxicity, as they look very similar on colonoscopy or biopsy?
So, it's, if a patient is already on mycophenolate, it's very, very unlikely that, he or she would be having Crohn's disease, unless it's a very, it's an immunomodulator. It's very unlikely for a patient who is on a, heavy dose of immunomodulator to have any of these, active Crohn's disease side by side. But you having asked the question, endoscopy may not always give you the answer in such cases. You may have to resort to a biopsy, which may, if the biopsy shows granulomas, you're very sure that it's Crohn's disease. So, and then there is, radiology, presence of strictures, all of these could favor Crohn's disease than mycophenolate-induced GI toxicity. And it's not very common. It's not very common for mycophenolate-induced GI toxicity to develop as well. And I have not seen one, to be honest. And I have not heard of anyone, having seen such a case either. Having said that, maybe it's possible that you're probably referring to immune checkpoint induced colitis, ICI colitis, which immune checkpoint inhibitors are coming up in a big way in the management of cancers. You may already be knowing about it, pembrolizumab and nivolumab, all of these immune checkpoint inhibitors. Immune checkpoint inhibitors are associated with flares of autoimmune diseases. Latent autoimmune diseases can be flared up, and de novo also autoimmune diseases can get flared up. So immune checkpoint induced colitis would resemble Crohn's disease and or ulcerative colitis, inflammatory bowel disease very much. It is at times very hard, but have a patient with who has recently received immune checkpoint inhibitors, you presume it to be immune checkpoint inhibitor induced colitis, and the treatment is also fairly similar. It's you have to try steroids, and in cases of non-response to steroids, you may even have to resort to anti-TNF agents as well, and even vedolizumab. All of these drugs which are useful in the management of inflammatory bowel disease are also have also been found to be useful in the management of immune checkpoint. So it's a new entity that has come up after the introduction of these immune checkpoint inhibitors, and it's a lot of clinical, endoscopic, histologic parameters all overlap with IBD, and the management is also very much similar. So this is a new kind of inflammatory bowel disease that has developed in the past 5 to 10 years. That is the ICI colitis, immune checkpoint colitis. Anything else? Any other questions?
Yes, sir. One more question is, what is the association of NOD2 or CARD15 with Crohn's disease?
NOD2 is, NOD2 is as far as I know, NOD2 is nucleoside oligonucleotidase domain or something. Node is a is involved in the PAMs usually activate node and trigger Crohn's trigger activity of inflammasomes leading on to inflammation. So node 2 mutation has been particularly implicated in the pathogenesis of Crohn's. It's one of the most important mutations to be implicated in the pathogenesis of Crohn's disease. But does it have any significance? It does not have any significance in the maths. It's something you can, drop in a fancy talk, but it does not have much relevance in clinical management with Crohn's disease.
Thank you, sir. Sir, one more question is, can IBD become malignant?
IBD can become malignant. It's ulcerative colitis, which is very commonly implicated in, there is always a risk of patients with ulcerative colitis developing colorectal cancer, but it's very uncommon for a patient with Crohn's disease to develop adenocarcinoma. It's not unheard of. It can occur, but it's not as big a problem as it is in ulcerative colitis. Any other question?
Yes. So one last question is, can active TB develop during anti-TNF therapy in IBD patients without any history of latent
Yes.
lesions?
Active TB can develop during anti-TNF therapy. It's fairly common to occur, and in studies from the West, it's less than 1%. Less than 1% of patients who are given anti-TNF therapy develop active tuberculosis during the course of anti-TNF therapy. In the West, it's as low as 1%, but in India, it can be as high as 5 to 10%. That's what has been shown in studies from India, because a lot of us have latent TB, and it could flare up during anti-TNF therapy. And these are patients, mind you, who were tested extensively for the presence of latent TB, who were later given anti-TNF therapy after extensive tests, which include CT of the chest, IGRA, ANTO, and after all of these tests are negative for tuberculosis, these patients were given anti-TNF therapy for the management of Crohn's disease and ulcerative colitis. But in this cohort, as much as 10% of patients developed a flare of tuberculosis, as shown in a study which was published from the Pharmd Institute a couple of years back.
Thank you, sir. So that brings us to the end of the question and answer session. On behalf of the Pharm D community, I would like to thank our speaker for today, Dr. Deepak Madhu, sir, for such an informative and engaging session. Thank you so much, sir, for taking time out of your busy schedule to conduct this lecture. Sir, I also want to apologize for the delay of today.
That's okay. Thank you. Thanks a lot. It was
Thank you so
very
much.
interacting with all of you. And just in case any of you have any doubts, you can you can send me your queries by email or WhatsApp me, or even call me if you want to have an interactive discussion. Thanks a lot.
Thank you so much, sir.
Thank you, sir. I also want to thank our participants for today. Thank you for joining this session. Participants, please make a note. The next session is on Saturday. The topic is ulcerative colitis. Also, I want to again ask everyone to complete their attendance criteria. The attendance criteria The attendance has dropped since the third session. Please make a note that 80% attendance and submission of the assessment is compulsory to get the certificate. So, thank you everyone for joining today.